Our Department of Population Health Management and Payment Innovation is charged with understanding the true drivers of health outcomes amongst a population and then thinking about how we redesign care and payment strategies to enable us to have a healthier population.
My name is Dorian James. I'm a respiratory therapist and been in the field since about 1985. I originally worked at St. Joseph's Hospital, and I had a significant interest in the asthma patients that were coming into the emergency room because there was a high recidivism rate. And so eventually we developed an asthma program at St. Joe's Hospital.
And I've been at the school system, at this particular school, in fact, for
Mhm.
10 years now. And I have about 1,400 kids that I'm in charge of. And the idea is to try to get them before they get that sick so they're not using the emergency room as much. So a lot of it, what I do is teaching and counseling and guiding and referring so that
whenever we kind of recognize in our dispensing system that the patient's getting their inhaler for the first time and if they haven't used it for a long time, we make sure we educate them. We have very patient-friendly videos on our iPad that we have, and there's options that we can select. There's different kind of inhalers, as we all know. It could be a Pro Air, it could be an Advair Discus, which works different. So we have to give them pearls about each inhaler. So we select, and there's different kinds of videos on the iPad so the patient can watch the video.
On a daily basis, I look at our hospital census for all of our asthma patients, and I do education for both the patient and the family, depending on the patient's age and their level of understanding, making sure that parents understand their medications, why it's important to get their medications, make sure that they are able to use the devices like a spacer, or peak flow meter, or nebulizer, and then an understanding of their asthma plan. How do I change medicine as my symptoms change?
So what am I as a pediatrician going to do about the fact that a child lives in a housing environment that may have mold, or the child may be exposed to environmental tobacco smoke, not because a caregiver smoked, but because the person across the hall does. And that is a very enlightening exercise for us, that to have the biggest impact on the population that we were trying to address, we're going to have to partner in new ways. We're going to have to collect information that's different than what we collect. And we're going to have to figure out how to incentivize this treatment modality, if you will, which currently is not a treatment modality.
One, asthma has a higher prevalence in minority communities, and it has a higher prevalence in low-income individuals as well. And so Milwaukee has the highest population and concentrations of those two populations in the state. So when you look at why the outcomes are so bad for a population that has traditionally had these poor outcomes, then you'd have to determine how do you overcome those barriers in order to improve those outcomes. And so when we look at some of the barriers, the biggest one is always education, and that's for anybody.
Our biggest problem, I think, with the asthma is that a lot of my kids go to the emergency room when they have a bad asthma attack, and then they never follow up with a primary care doctor.
Right.
So they go to the health department to get their shots, and they don't see a primary care doctor. They go to the urgent care to get this and that. So they're never sitting in a home spot to get consistent care. And of course, in the emergency room, they're just helping them with that emergency. So the kids are a little overwhelmed and don't know what's going on a lot of times too.
Right. So when we so there's a few drawbacks about how the medications are manufactured and packaged, especially for the inhalers. We would love to kind of label the inhaler with the label that we have for the prescription, where it would say 1 puff twice a day for Advair, for example. But unfortunately, we're not able to label the inhaler because it comes in a foil pack.
Mm-hmm.
And as soon as we open the foil pack, they're only good for so long.
Right.
So we cannot open the inhaler and label the inhaler, unfortunately. It's a similar case for all the albuterol inhalers that come. They're all in a foil pack, and it's hard for us to open it because if we open it again, there's an issue with expiration. So that's the reason. And when we label the box, the patient goes home, discards the box. Sometimes they discard the box, so they wouldn't have the instructions on how to use the inhaler. So that's a restricting factor that we have.
I think asthma's unique in that you have symptoms some days and you have your good other days. So I think sometimes it's hard for people to understand and buy into why do I need to take a daily medicine when I feel great. So oftentimes we see that they have stopped their daily medicine and then end up having asthma symptoms and then try to restart that daily medicine, and at that point it's oftentimes too late. Too much inflammation has occurred and the inhaled steroid isn't going to kick in quick enough to make a difference. So I think that's one of the big reasons.
When we look at asthma outcomes for our population, one of the key drivers of poor asthma outcomes is indoor air quality. So I, as a pediatrician, right now can't do a thing about the air quality in your house if you were my patient, or the fact that your caregiver smokes. I have no way to bill for those services, nor am I incentivized to address those very real challenges to your asthma management. I can prescribe all the right medications, I can give all the appropriate teaching, and I'm going to have very little impact on your asthma outcomes if the main driver of asthma for you is indoor air quality. So part of our approach is testing those new models of care.
A lot of different types of inhaler devices for respiratory management. And so they all have different techniques. And if the patient doesn't know how to use them, then they won't get any effectiveness of the medication. Patients also need to understand what they're treating as well, so that they would understand the necessity for taking these medications on a regular basis. Is much different than the other chronic diseases such as diabetes. You got to take your diabetes medications every day because your blood sugar is going to get high, and high blood pressure pretty much the same way. Asthma, the symptoms come and go. So you got variable symptoms. And so people may not understand the necessity of taking medications at a time when they're not having symptoms.
A lot of my students aren't on daily medication for the asthma, so they're only carrying their emergency inhaler that they got from the emergency room, or they've run out. They're not using spacers. They don't even know what spacers are, most of them. They're not using their inhaler appropriately. They're taking it whenever they feel winded or they've got a head cold, or so they're using it inappropriately. Some are using it way too often. A lot of them, it's hard with the spacers to always know if there's medicine in it. In the good old days, you could shake it or float it, and that stuff. But now, if they don't have the counter on them, the kids think that there's still medicine and it's not, or it's expired. If they had an inhaler, it would really work well, because we could say, okay, let's listen to your lungs, let's see if you need that, and they could use it and go on with their day, which would be ideal. A lot of the kids are using the wrong one, like they might be using their daily as if it's an emergency inhaler, because there's not a way for them to tell and to remember which is which.
Right.
So if they bring them into me, that's good. I can say, okay, this one says right here on the bottle, take this twice a day. This one is for an emergency, when you really feel it. And we can listen to them and teach them when to use it more appropriately.
So the other very important thing is that we're pharmacy, and Pharmacy Society in Wisconsin is trying to work very closely with the physicians or providers, healthcare providers in Wisconsin, and making sure that we have a closed loop of care for our patients, so there's nothing being lost, no piece of information about the patient care is being lost in the whole process of getting it to the patient. And very often we notice that patients have been prescribed 2 different kinds of inhalers based on how they are doing on their peak flow meter. So they're given an asthma action plan by their provider, but it's just with the patient. The pharmacy does not receive a copy of the asthma action plan, so we can also be a part of the education, because we're the ones who actually give the inhalers to the patients and talk to them about it.
I think getting our parents and our families to buy into the importance of why you have to take an inhaled corticosteroid daily, how that works, what it's doing inside the lungs to prevent future asthma exacerbations. I think the other important thing is recognizing symptoms early. Oftentimes we hear our patients or our parents say, well, I wasn't wheezing, so I didn't take my albuterol, but they've been coughing, they've had cold symptoms. We know colds in kids is one of the number one triggers for an asthma attack. So helping our families and our patients to understand and recognize the early warning signs and initiate albuterol treatment during those early signs, hopefully to prevent the asthma from getting worse.
It may make more sense for us as a healthcare delivery system and us as a payer of healthcare services through our Medicaid health plan to pay for a HEPA vacuum or an air filter, or for counseling for someone who is not my patient, if that is going to have a greater impact on your asthma outcomes. So those are the types of things that we're exploring. And then, based on what we learn, try and change the incentives. If I am incentivized to understand what's really affecting asthma outcomes for the children that I treat, then I am better equipped to be able to meaningfully change those asthma outcomes. I may now be able to bill for a HEPA filter, or the family may be able to purchase that and have that as a covered benefit. I may be able to counsel family members who are not my patients on smoking cessation and trigger remediation in the homes if that is a service that is now covered.
And so there's a direct relationship of compliance and number of visits. It's an inverse relationship. So the more visits you got to make, then the lower the compliance is. We can do all those services in our first visit. So we have the testing equipment here. We've got X-ray next door, and we got lab on the corner. Everybody can get all their tests done on the same day. And so when they come in, we can get the testing done. And once we get the testing done, we can do the medication planning. And then we have a pharmacy on the corner. They can pick up their medications when they leave at the end of their visit. So when they come in to see us, they start the medication plan that's going to make them start to feel better on the same day, not 4, 6 weeks, 8 weeks later.
I think the other thing that plays a big part of this is poverty. And when you have families who are looking at how they're going to pay for their housing, how they're going to pay for their electricity, putting food on the table, those types of things, your daily needs take precedence over asthma. So I think an important thing in helping families get to the point where they're using medications correctly, and that's important to them, is helping them meet their daily needs. So involving a social worker that can help with housing, or that can help with energy, helping pay for their energy bills, or helping them connecting to where they can get food stamps, or they can get shelters, things like that. If we can help meet those needs, then oftentimes families are able to focus on either their child's health or their own health, doing their daily medications and things like that.
I think that is the exciting representation of the interface between traditional public health and healthcare delivery. When we all partner in this way, we can truly, measurably impact the health of populations.